Peace. Welcome to the YouTube live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Yes. And peace, everyone. We had to take a nice little break. I wish that you got to catch up on some rest and reading. We pick up section 8. Common pulmonary pathology in acute respiratory care. This is section 8 of this book. We are getting up there. Love to all our friends and family. Love to all those that came before us and all those that are coming after us. When I got here, I had written a note to myself. Wow. I'll read it. It says, Uriel, you are doing it. Keep going. No one can stop you with God's grace. You have no rival. Chapter 29. Pulmonary edema. Wow. Page 431. I'm your moderator and narrator, Uriel Neville Riley. Happy Saturday. It's the 1st of November. The tracheobronchial tree, respiratory bronchioles, alveolar ducts, and alveoli must be maintained in a relatively dry state for the lungs to function adequately as a gas exchange organ. Appropriate diffusion and V over Q relationships require a interstitial space without excessive water content. The tightness of alveolar epithelial cell junctions, see Chapter 1, appears to provide an effective barrier to water entering the air spaces until either the epithelial cells are directly damaged or interstitial fluid pressures become excessive. Since capillary endothelial cell junctions are normally permeable to water and small molecules, see Chapter 2, it appears that prevention of interstitial water accumulation is the result of several phenomena in delicate balance. 1. The pulmonary vascular system is normally a low pressure system. Therefore, the capillary hydrostatic pressure forcing fluid from blood to interstitium is relatively small. 2. Larger intravascular molecules are responsible for a counterforce, or colloid osmotic pressure, tending to keep fluid within the vascular compartment and completely counterbalancing the hydrostatic pressure under normal conditions. And 3. The pulmonary lymphatics normally remove any excess water from the interstitial area. Peace, YouTube. Welcome. Thank you for being here at the peaceful part of YouTube where we read books and learn from masters. Thank you so much. Pulmonary edema may be broadly defined as the excessive movement of fluid from the vascular space to the interstitial and air spaces of the lung. Numerous pathologic conditions may upset the normal delicate water balance and result in pulmonary edema. For the clinical purposes of this discussion, pulmonary edema will be divided into two major categories: cardiogenic and non cardiogenic. Cardiogenic pulmonary edema, pathophysiology. Pulmonary edema, as a consequence of increased pulmonary vascular hydrostatic pressure, is most often related to left heart failure. Myocardial disease, either acute or chronic, table 29.1, is the most commonly encountered cause of a negative inotropic state. In other words, inadequate myocardial contractility results in increased end diastolic volumes, which result in increased left atrial pressure. See chapter 26. And pulmonary vascular engorgement. When the patient is being monitored with a pulmonary artery catheter, elevated pulmonary wedge pressures will be measured. The increased pulmonary blood volume and elevated hydrostatic pressure result in fluid movement into the interstitial compartment. This increased water content results in significant enlargement of the pulmonary edema. The lymphatics initially function to remove the excess fluid, but eventually are overwhelmed by the ever increasing extravasation. As pressures become even higher, the alveolar epithelial barrier is broken and fluid extravasates into the alveolar spaces, ducts, and respiratory bronchioles. This process is now termed alveolar pulmonary edema. Clinical presentation. In earlier pulmonary edema, interstitial edema, the main complaint generally is dyspnea. The patient tends to manifest tachypnea while maintaining reasonably normal tidal volumes, i.e., an increased minute ventilation is common. Blood pressure remains reasonably normal, with an associated mild tachycardia. Chest auscultatory findings are usually limited to basilar rales and a few expiratory wheezes. The wheezing associated with pulmonary vascular engorgement is referred to as cardiac asthma. Chest x-ray remains unremarkable except for evidence of lymphatic engorgement. Atrial blood gases reveal reasonably acceptable PCO2 and pH values with mild to moderate reduction in PO2. Okay, here's table 29.1, the top of page 432. Causes of cardiogenic pulmonary edema. And we have right here a note down at the bottom. It says most often these physiologic insults are associated with a pre-existent degree of chronic congestion, heart failure. All right, so table 29.1, acute myocardial infarction, mitral valvular disease, excessive fluid administration, arrhythmias, rheumatic heart disease or myocarditis, pulmonary embolus, infection, sepsis, anemia, severe thyrotoxicosis, malnutrition or beriberi, systemic hypertension, and renal failure. There you go. Top of page 432 for all those taking notes and reading with us. Thank you so much. Happy Saturday. Happy November 1st. We're reading Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. So that's the first table of this chapter 29 in the 8th section. A classic finding associated with pulmonary edema is called paroxysmal nocturnal dyspnea, or PND, after lying supine for several hours, which means face up, right? You're just laying. Okay. For several hours, the patient will suddenly wake up with extreme respiratory distress and paroxysms of coughing and wheezing. Relief is obtained by sitting upright at the side of the bed. These episodes, though usually of short duration, may last for several hours, in which case the patient will also demonstrate diaphoresis and frothy secretions. As interstitial edema progresses to a more severe stage, alveolar pulmonary edema, the patient becomes more severely stressed. Dyspnea, shortness of breath, tachycardia, hypotension, and frequent coughing are present. The cough may produce a frothy, blood-tinged sputum. Auscultatory chest findings now consist of bilateral wet rails, rhonchi, and diffuse expiratory wheezes. The patient refuses to assume the supine position and is often diaphoretic, agitated, and manifests direct evidence of myocardial instability. Chest X-ray reveals vascular engorgement, diffuse haziness throughout the lung fields, and often a classic butterfly pattern. Arterial blood gases reveal a marked hypoxemia, even with aggressive oxygen therapy, a normal to slightly elevated PCO2 with corresponding pH change and a metabolic acidemia. If untreated, the process may progress to a state of massive alveolar pulmonary edema involving all lung fields and associated with cardiac hypoxia, CNS hypoxia, and eventually death. During this terminal phase, the patient becomes obtunded and comatose and shows minimal evidence of adequate perfusion, e.g., cold, clammy extremities, absent urine output. If an endotracheal tube is placed, copious and continuous frothy, blood-tinged fluid emanates from the tube. Arterial blood gases will reveal severe hypercarbia and acidemia of both respiratory and metabolic origin, and marked hypoxemia even with maximal oxygen therapy. Therapy. The symptomology of cardiogenic pulmonary edema is readily relieved by decreasing pulmonary vascular hydrostatic pressure. Appropriate therapeutic intervention prior to cardiopulmonary collapse is usually dramatic. There are three primary goals of therapy. 1. Decrease venous return. 2. Increase ventricular inotropy. And 3. Improve gas exchange. Although the physician and nurse are primarily involved with the first two regimens, it is essential for the respiratory care practitioner to comprehend the therapy so that he or she may appropriately participate in the overall care. On the other hand, although the third area of therapy is primarily the involvement of the physician and respiratory therapist, it is essential for the nurse to understand the role and indications for such therapy. Top of page 434 in the 29th chapter. Therapy to decrease venous return. Fowler's position, sitting up. Pulmonary vascular intraluminal pressure increases approximately 2 millimeters Hg for each inch below the heart. Since the root of the pulmonary artery lies in the mid portion of the chest, the patient in pulmonary edema accomplishes the following by sitting up. 1. Minimizes areas of lung where excessive hydrostatic pressure exists. 2. Decreases pulmonary blood volume by decreasing right heart venous return secondary to peripheral pooling. And 3. Gains mechanical pulmonary advantages, increase vital capacity for the work of breathing. Rotating tourniquets. Placing venous tourniquets on 3 of 4 extremities impedes venous flow and promotes pooling of blood, thereby reducing the central or core blood volume. This reduction in vascular volume results in decreased right atrial pressure and eventually decreased venous return to the left heart. See chapter 26 and 27. The tourniquets are rotated every 15 minutes so that no single extremity is continuously obstructed for more than 45 minutes. Morphine sulfate, middle of page 434 in the 29th chapter. Appropriate administration of morphine sulfate, 1 to 2 milligrams incrementally, given intravenously, will accomplish considerable venodilation and venous pooling. In addition, morphine is a euphoric and a psychologic effects can reduce anxiety and thereby decrease the release of endogenous catecholamines. However, all of the exact modes by which morphine improves these patients is not clear. Careful monitoring of respiratory function is essential so that the respiratory drive is not adversely affected. Diuretics. Furosemide, Lasix is rapid acting. Removal of salt and water via the kidneys results in decreased vascular volume. This drug also has an immediate direct vasodilating action. Phlebotomy. Removal of 300 or 250 to 500 milliliters of blood may be life-saving in severe conditions. Thank you so much for the likes and subs. We're pushing towards 600 subs on this peaceful part of YouTube where we read books and learn from masters. I'm Master Fitness Trainer, Uriel Riley. Thank you so much for being here and reading with us, part of the book lovers community. So, highest heart, love, and honor. Thank you so much. Happy Saturday. Happy November. We made it. November 2025. Wow. We're still reading books. You know it. Had a beautiful year healing session yesterday. Wow. I got to tell you about that. This modality is the one. It is definitely the one for the future. Therapy to increase inotropy. Diminishing pulmonary vascular volume by decreasing venous return results in decreased ventricular filling. The decreased end diastolic volume may allow improvement in contractility. See chapter 26. If this does not occur, therapy aimed specifically at increasing myocardial inotropy may be instituted. Aminophylline. This has been a popular mode of therapy for many years. The drug has beta stimulating properties and, when effective, is believed to improve inotropy as well as vasodilate and bronchodilate. The popularity of this mode of therapy in pulmonary edema does not appear justified in the medical literature. Dopamine, isoproterenol, or isoprel. This may be instituted in severe pulmonary edema that is not responsive to usual therapy. Digitalis, cardiac glycosides. This is seldom used in acute pulmonary edema due to the potential problems associated with rapid digitalization. Decrease afterload. Nitroprusside infusion is often attempted in very refractory causes or where systemic hypotension is present. Therapy to improve gas exchange. Oxygen therapy. Since hypoxemia is present and is caused in large part by shunt effect, V over Q inequality, the hypoxemia should with interstitial edema, yes, be reasonably responsive to oxygen therapy. This is especially true with interstitial edema. Initial concentrations of 30 to 60% are recommended, preferably by high flow system. Greater than 60% oxygen is usually not a benefit and indeed may result in a worsened state of oxygenation. See Chapter 7. The exception to this general statement is the patient with massive pulmonary edema and severe cardiopulmonary instability. 100% oxygen should be administered until the situation improves. Arterial blood gas measurements are required, and in severe cases, measurement of pulmonary artery blood gases is extremely helpful. Appropriate oxygen therapy is indicated in all pulmonary edema. IPPB therapy. The use of this modality will result in some patients responding dramatically, whereas in others, it causes further deterioration. This can be best explained by identifying the nature of the heart failure. For example, with isolated left heart failure, the left ventricle may be depending on the right ventricular output to maintain a higher preload. If IPPB therapy causes an acute decrease in systemic venous return, the result may be a catastrophic drop in left ventricular output. On the other hand, the patient with both right and left ventricular failure may experience a more moderate decrease in right and left ventricular filling with IPPB therapy. This may result in a beneficial reduction of biventricular preload. When IPPB therapy is administered, the patient must be carefully monitored and therapy discontinued if detrimental. If tolerated, there are some advantages. One, work of breathing is transiently diminished. Two, deep tidal volumes may improve alveolar ventilation and oxygenation. And three, many patients have decreased anxiety because they feel something is being done for them. IPPB therapy must not be confused with IPPV, whose indications and applications have been discussed in chapters 22 and 23. Intubation. This therapy is often indicated in severe cases and usually for the purpose of supporting the ventilation by positive pressure means, IPPV. Often, the foaming and frothing may be so copious that ventilation is hindered. We have found administration of 20 to 50% ethyl alcohol by aerosol to be dramatic as a defoaming agent. The bubbles and froth disappear, and ventilation and oxygenation improve. Do not assume that the pathologic process has improved. The alcohol aerosol is only a temporizing maneuver while more definitive therapy is being accomplished. Peace. Happy Saturday. Much love. Much love. Thank you so much to the book lovers community that we're a part of, all those authors. And man, we love you so much. We're going to be getting into reading the new book soon. Look at how much is left. That's all that's left. Thank you so much. We're in the 29th chapter. Live from the light here in LA. PEEP therapy. With the patient intubated, application of 5 to 10 centimeters H2O, PEEP, is often beneficial in improving oxygenation until the pathologic process is controlled. Non-cardiogenic pulmonary edema. These disease processes must be caused by 1. Decreased colloid osmotic pressure. 2. Altered capillary permeability. 3. Altered lymphatic function. 4. Damage to the alveolar epithelium. Or 5. Combinations of these factors. Osmotic pressure. Colloid osmotic pressure, COP. A substance dissolved in a solution, a solute, contains a force that can potentially attract water molecules to itself. The magnitude of this force is directly related to the solute concentration and is referred to as osmotic pressure. The quantity of osmotically active particles in a solution is referred to as osmolarity and is expressed as milliosmoles per liter or milliosmoles. Yeah. OSM over L. Substances such as sodium chloride, NaCl, dissociate in solution and form 2 osmotically active particles, Na plus and Cl negative, whereas substances such as glucose, C6H12O6, remain dissociated and account for only 1 active osmotic particle. Normal serum osmolarity is 285 to 310 MOSM over L. Total osmotic pressure in blood would exceed 5,000 millimeters Hg if most of these particles could not freely move across membranes separating the fluid subcompartments of the body. The physiologically significant osmotic pressure that will determine water distribution among the subcompartments is related to particles that are limited to one of the compartments. All right, so this is table 29.2. Says transcapillary fluid exchange. All right, and J equals K parentheses P cap minus PIS, and then parentheses minus pi PL minus pi IS. All right. So J equals net fluid movement across capillary membrane. K equals capillary permeability factor. P equals hydrostatic pressure in the capillary and interstitial. And pi equals the oncotic pressure, plasma, and interstitial. This is, again, table 29.2, the transcapillary fluid exchange. Thank you so much for reading with us. It's Heart Love. We're in the 29th chapter. This is the second table of the chapter. As you see, transcapillary. Thank you so much for reading with us. All right, transcapillary fluid exchange. Top of page 437. COP. Large solute particles cannot normally pass through capillary micropores with ease and thus would essentially be contained within the vascular compartment. Colloid particles such as albumin, approximately 90,000 molecular weight, and globulin, approximately 200,000 molecular weight, are particles present in significant quantities in blood. They do not pass freely through normal capillaries and thereby exert a colloid osmotic pressure that will hold water in the vascular compartment. This pressure is often referred to as oncotic pressure. Normal COP, oncotic pressure, is 25 to 30 millimeters Hg and comprises approximately 1.6 MOSM over L. Right? The relationship between intra and extravascular oncotic and hydrostatic pressure was classically expressed by Starling, Table 29.2. Simply stated, distribution of fluid between the intravascular and interstitial compartments will be greatly determined by the balance between oncotic and hydrostatic pressures within those compartments. Decreased COP. Peace, hi, it's Heart Love. Thank you. Yes, it is a good book. Thank you so much, Dragon Puppet. Hi, it's Heart Love. Thank you for reading with us. Much love. We are in the 29th chapter reading this book. Live from the light here in LA. Decreased COP. This is seldom the sole cause of pulmonary edema, but is probably a contributing factor more often than is realized. To be sure, chronic debilitating disease result in decreased total body colloid. However, the most common clinical problem is a physiologic insult that affects the capillary permeability and allows abnormal movement of colloid to the interstitium. If the lymphatic system cannot adequately remove the interstitial colloid, the result will be movement of water into the interstitium. It should be noted that this response to physiologic stress is not an acute change in the total body colloid, but rather an acute change in the distribution of colloid from blood to interstitium. Most acute decreases in COP are secondary to this type of phenomena. Altered capillary permeability. Top of page 438. Of clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Yearbook Medical Publishers, 1979. Yes! We're bringing it to you live here from the Life for Free. We love the people. We want the best for the people. So this is part of our givings, right? Part of our service. So I love to provide the service of reading something that is very valuable, very valuable. And being able to understand this information gives us knowledge of self, knowledge of care, and how to be a respiratory professional in our own right. So when we master ourselves, we can master the world around us. and harmonize with it. And when we can heal ourselves, we can help heal others around us. Thank you so much. Hi, it's Heart Love. Thank you for being here, for the likes and subs. We're pushing towards 600 subs on this quiet, peaceful part of YouTube where we read books and learn from masters. And we're in the 29th chapter of this book. Altered capillary permeability. Many infectious and inflammatory processes are believed to alter the integrity of pulmonary endothelial cell micropores. These appear to be more vulnerable than most other endothelial complexes. The factors affecting the pulmonary endothelial cells are an active area of research at present. See Chapter 30. Altered lymphatic function. The pulmonary lymphatic system has been described in Chapter 1. Although little specific knowledge is available, it is obvious that alterations in lymphatic function have profound effects on fluid distribution in the lung. Ding! The movement of secretions has everything to do with our blood flow and the lymphatic system. That's why it's so important to take long walks if you have the ability. You're literally moving the secretions in lymphatic system through your body as you breathe and as you stride and pace. Okay. Alveolar epithelial damage. Alveolar type 1 cells form a watertight pavement epithelium. Alveolar fluid tends to occur either when interstitial pressure is excessive, cardiogenic edema, or when the epithelium is damaged, lung burn, severe hypoxia, prolonged atelectasis. Little specific information is known concerning the factors that control or affect alveolar epithelial function. See Chapter 30. Now we know. Summary. Although well-established pulmonary edema is a reasonably easy clinical diagnosis, the differential between cardiogenic and non-cardiogenic origins is often difficult, especially in the critically ill patient. This is probably because factors causing cardiogenic and non-cardiogenic pulmonary edema often occur simultaneously. One type of non-cardiogenic pulmonary edema is known as the adult respiratory distress syndrome, ARDS. ARDS. The following chapter is devoted to discussion of this entity. We just completed chapter 29. Yes! Completion of another chapter or one read. Yes! Of clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. So now, when we reconvene, we will move into chapter 30. I want you to have a wonderful day. Game 7 of the World Series. Go Dodgers. Much love, live from the light here in LA. Love to all those in Toronto as well. All our friends and family in the Caribbean that are going through anything. Continue to shake it up in the world on YouTube by reading books and learning from masters. a master fitness trainer, Uriel and Riley. Thank you so much for reading with us and staying in the light. You know, that's what we want to do. Stay in the light. We're shining that light to everyone else around us. That's why we stay positive. That's why we come on here to show you and read huge, masterful books like this to show you that you can do it. You can. And as a master fitness trainer and healer that's traveled around the world, that's what I love to do. To show people you can do it. That's what us light workers do. How clean and beautiful. That's what we do. Remember, if anything starts to get confusing in these readings, I will put the vocabulary in the descriptions. Thank you so much for reading with us. Hi, it's Heart Love, Golden Healer, right? Yes. You shake it up. Hey, 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 much love. I love y'all so much. Yes, it is very good. Thank you so much for being here and reading with us. Thank you for the likes, subs, and shares. We are moving up the scale. That's for sure. Definitely. Let's have a glass of love water. All our friends and family, all the beautiful solar returns coming up. Yes. We have magnificent people in our world. We want to show them love. You know, thank you so much. Hi, it's Heart Love. Mm. Oh, that's so good. I love you. I love you. I love you. Love water for the people. Reading to the people. We had a wonderful year healing session now. Now we are in the 9th session, right, of this patient that's had his second stroke. And when I got to him, I told y'all before, his arm was originally like this, right? Locked up. You could, it was very hard to extend out. I couldn't even get into his fingers. Well, yesterday, when we did your healing session, right? His arm is down here now. And I could just go through and work through his fingers all up and down. And they were literally spreading apart. They were no longer like this and locked in. It is so powerful. Telling you, I'm definitely a goat healer. Like for real, man. Because I combined 3 modalities, natural modalities, into one. Your healing. Diaphragmatic breathing combined with assisted stretching and pressure points to the hands and feet. Clearing out the blockages. We also throw the brio on. So the head massager is working while I'm going through his pressure points on his fingers. It's just so masterful. It really is. So grateful and thankful for all I have now and all that's coming to me. Thank you so much. I love you. I love you, you. I love you, you. And you know, because I love me. All right, so have a wonderful Saturday. I will see you soon. When we reconvene back to chapter 30. Peace, peace.